Good evening. I'm Beth Emery, a past president of Alamo Breast Cancer Foundation and ABCF's alternate to the NBCC board, and a 17-year survivor of HER2 positive breast cancer. Welcome to ABCF's 28th Alamo Advocate Program as part of the San Antonio Breast Cancer Symposium. We were asked by the leaders of SABCS 29 years ago to create a program that would enhance the educational experience of advocates and improve their relationship building experiences. And we're pleased to have you all here and those of you who are in virtually. This year we have one of the largest classes of Alamo scholars in our history, 36 scholars. 30 are sponsored by Alamo, and 4 are sponsored by Teresa's Research Fund, and 2 are sponsored by the Metastatic Breast Cancer Alliance. The scholars come from 16 states and Puerto Rico and 8 countries. We also have 7 advocates serving as scholar mentors this year. This year's Alamo Advocate Program is dedicated to the woman who founded ABCF and the Alamo Advocate Program, my mentor, Dale Eastman. We are delighted that SABCS has dedicated the entire week to her as well, and that will be discussed tomorrow in the plenary session. Now, one of the things that has been a National Breast Cancer Coalition tradition, and we adopted as proud members of NBCC, is a moment of silence. And tonight, the moment of silence is going to be Raluca Gudry, who was passionate about connecting with other metastatic breast cancer patients, sharing resources and exchanging stories to support one another on their individual journeys. She wanted to become more knowledgeable about the science behind breast cancer and move into research advocacy. And in 2023, she attended the San Antonio Breast Cancer Symposium as a Twisted Pink scholarship recipient. It ignited her desire to become more involved. She became very active in breast cancer advocacy, volunteering with many organizations. She volunteered for the After Breast Cancer Diagnosis as a peer mentor to newly diagnosed metastatic breast cancer patients, participated in Graff poster reviews with researchers, hosted support group sessions for newly diagnosed metastatic breast cancer patients, was a Project Life volunteer and a Hear My Voice advocate, and a leadership volunteer with Living Beyond Breast Cancer. She was interested in reviewing grants and serving on research projects and took every opportunity to learn more about breast cancer. She participated in Spinning Science for Metastatic Breast Cancer Coalition and graduated from NBCC's Project Lead in 2024. While not learning or helping others, she also helped as a fundraiser for breast cancer research. Raluca passed away January 29th, 2025. Please join me in a moment of silence for Raluca Gudry. Okay, thank you. There are more seats down over here on this side, and of course, those who come late get the front row. We want to acknowledge our sponsors who make this program possible. Their logos are shown up on this slide. Our premier sponsors are Genentech, Pfizer, Menarini Stemline, Lilly, Novartis, and Cyber Media Productions. Collaborating sponsors are Daiichi Sankyo, Merck, AstraZeneca, and Natera, and our contributing sponsor is Exact Sciences. Now I'm pleased to turn it over to the moderator for tonight's Hot Topics panel, Maria Boyce, who is the lead for our Alamo Scholar Program.
Thank you, Beth. And good evening. Welcome to the second of our 3 Hot Topic mentor sessions. My name is Maria Boyce, and I am a patient advocate from Houston and a proud graduate of NBCC's Project Lead. I serve as the patient advocate representative of MD Anderson Cancer Center for the Translational Breast Cancer Research Coalition. And as Beth said, I am proud to serve as the scholar lead of the 2025 Alamo Scholar Program and a member of the AAP Planning Committee. This year, AAP was able to regain its seat on the SABCS Planning Committee, and through the hard work of the 4 patient advocates on the Planning Committee, including our AAP Director, Mary Jimenez, we are proud to have patient advocates participating in every SABCS program this year for the first time. This evening, each of our 5 mentors will spend about 10 minutes highlighting what caught their attention at today's sessions. And after that, we'll open the floor to questions. And it's now my honor to introduce our mentors. Dr. Taiwo Adesoye is an assistant professor in the Breast Surgical Oncology Department at the University of Texas MD Anderson Cancer Center, where she has established a successful collaborative clinical practice delivering high-quality, multidisciplinary, patient-centered care to complex breast cancer patients. Dr. Adesoye collaborates with translational researchers to study biomarkers of treatment response and resistance in clinical trials. Her work aims to bridge clinical and laboratory research to advance evidence-based breast cancer care and precision oncology. Next is Dr. Etta Pisano, who holds faculty appointments in radiology at the University of Pennsylvania and the University of North Carolina at Chapel Hill. Her career has focused on breast imaging with a special emphasis on the development and testing of new technologies, most recently including the application of artificial intelligence and machine learning to breast cancer screening. Next is Dr. Alastair Thompson, who is a professor and chief section of the breast surgery, co-director of the Lester and Sue Smith Breast Center, and the Olga Keith Weiss Chair of Surgery at Baylor College of Medicine. In addition to his research and focus on breast surgery, he is involved in a wide variety of clinical trials. Dr. Jenny Chang is the director of the Houston Methodist Dr. Mary and Ron Neal Cancer Center and holds the Emily Herman Presidential Distinguished Chair in Cancer Research. Her recent work has focused on the intrinsic therapy resistance of cancer stem cells and the role of targeting inflammatory pathways to change tumor immune microenvironment. And last but definitely not least is Dr. Stephanie L. Graff, who is the Director of Breast Oncology at Brown University Health and the LaGuardia Cancer Center in Providence, Rhode Island. Dr. Graff is an associate professor of medicine at the Warren Alpert School of Medicine at Brown University and co-leads the Breast Cancer Translational Research Disease Working Group. Dr. Graff has broad experience as a principal investigator on over 100 clinical trials across all phases of drug development. Please join me in welcoming this wonderful panel. So let's start with you, Dr. Adesoye. What did you find interesting today?
So first of all, thank you for having me here. It's such a pleasure to spend time with you all. So 2 main things stuck out to me today. The first was the talk given by Dr. Giuliano. So he is the father of sentinel lymph node biopsy. As you all know, this is the technique that allows us to de-escalate axillary surgery. So we go from doing the highly morbid axillary lymph node dissection to doing more of a directed or targeted sampling of the lymph nodes. And he talked about his journey of changing the field. It was incredibly impactful to me as a surgeon because I started practicing when sentinel lymph node biopsy was standard of care. And so to hear this giant in the field articulate his experience, how he advocated for the research he believed in, He knew this was going to spare a lot of patients' morbidity, despite the, in spite of the resistance he got from colleagues, from people around the world. He said he got hate mail that's, his secretary wouldn't even let him read. He was persistent and forged ahead, continued to show the evidence so that people would, see the point he was trying to make, which is he wanted to spare patients, significant morbidity. And I found it quite encouraging at the end when he talked about even just this theory where people tend to think all of the change that will happen in a setting, in a field, has already happened. And it was particularly inspiring for me to hear that one, there's evidence to show that it doesn't matter what generation you're in. Everybody feels that way, but it is certainly not the case. And so certainly I walked away thinking, I'm gonna go roll up my sleeves and continue the work and make some good change. Then the second piece was the attention to toxicity, to symptoms. And this was one of the spotlight sessions I attended earlier, and I was really impressed by the different strategies individuals were using to mitigate toxicities in patients and to even understand it better. One study looked at using, graduated, how do I put it, doses of abemaciclib to help patients sort of ease into the recommended dose. And they were able to show that with this approach, patients could stay on the recommended dose for a longer period of time. Another study looked at the impact of the microbiome on patients' ability to tolerate therapy. And they found some interesting associations that they were going to study further. And it might be interesting to study patients in the beginning and say, can we predict how they're going to respond to treatment prior to starting therapy based on their microbiome, and and even recommend some adjustments because it's modifiable, right? You tell patients to eat certain things, they can actually change their microbiome. And then finally, another study looked at the idea of immune aging, and that chronic stress can cause immune cells to change and age in a way that may impact how you respond to therapy. So that was sort of like a summary of what I took away from today, and I'm sure there will be some more interesting insights.
Excellent. Dr. Pisano, would you like to go next?
Sure. I want to also reflect on Armando Giuliano's excellent talk about sentinel node biopsy. I was practicing when this happened, which is a little different. I'm a little older than she is. But I remember it very vividly, and just to hear about it, the resistance that was present among the surgeons who made up their minds. I mean, the fact that he got hate mail and had to really fight for it. And the part that most impressed me is his trial didn't accrue. He did a trial with the ACOSOC group. This predates the current system and the current trial groups. And they had to close the trial down because it wouldn't accrue because so many people had made up their minds. So I was struck by the fact that you can't be a researcher if you don't believe things can't change. Yeah. So I remember he talked about this end of history bias is what he called it, which she's already described pretty well. And I realized I don't have that bias, and I'm guessing very few people in this room have that bias or who do research, because otherwise, why would you do research? So I was really impressed with that talk. He gave an excellent talk. There were two other talks I want to talk about briefly. Electra Paskett, who really is a giant in the field of social determinants of health. She gave a talk in the same session that were divided between toxicities and social determinants of health and disparities in care. And I was really struck at this particular moment in our history where we're not supposed to say certain words on grants. We're not supposed to talk about disparities or social determinants of health right this moment. And she talked about how Medicaid expansion really created a natural experiment to show us how important social determinants of health were, in that there's clear data that screening has increased And outcomes have improved in patients who are on Medicaid in the states where they were put on allowed to go on Medicaid. So we're obviously reversing that right now, and we're going to do another natural experiment to show things will get worse. She has a paper on it, which she just is in press, which I thought was very interesting. She described, it's in Cancer Discovery, and it should come out any day now, about this issue about Medicaid expansion. So I just want to remind everyone, these things still matter, even if we're not allowed to talk about them, and or request funds for them even. And then the last talk I'll just focus on is the one that Angie DeMichelle, my colleague from Penn, gave on liquid biopsy. Mainly, I'm an imager, I do imaging research, and she basically called for the use of liquid biopsy with imaging as a way to adapt neoadjuvant therapies, to allow women to go more quickly to surgery, or to know that they have a low probability of success of therapies and maybe try different things. So I heard that call, and I will take it back to my colleagues at the ACR to see if we can help get some of these studies funded. So those are the three things I'd like to emphasize.
Thank you. Thank you. Dr. Thompson, I'd love to hear your thoughts about the day.
Well, thank you for inviting me along. Again, it's a real privilege and pleasure to be here. So I guess tonight is a pivot point between what we've heard today and last year, and the predominantly local regional general session tomorrow. And like my two colleagues, I loved hearing from Dr. Armando Giuliani, because he was so clear about the resistance to change that comes from us as clinicians, and the bravery and willingness of the patients who went into his trial and multiple other trials. It took several trials to force the surgical and radiotherapy community to actually change practice in how we manage the axilla. And that is still happening, because tomorrow we're going to hear more about what we do in the armpit around the world. And when you think of the morbidity that we can cause with surgery, with drugs, and with radiation treatment when we operate and treat the axilla, it's really very substantial, and affects the woman throughout her, hopefully, long life thereafter. So we're trying to be more thoughtful about things. The second thing he raised was that ability to persist in the face of doubters. And this is where I think for all five of us, patient advocates have helped us, have guided us in various avenues to try and make sure that if there's a good idea, it gets some airtime. It may not be the perfect idea for a trial, but it actually does get the chance to be aired and discussed freely. And as you alluded to, that's maybe not quite as easy nowadays as it was a year or two back. And then finally, as we look forward to tomorrow, if I may,
yes,
I would recommend that you go to the general surgery, the general session tomorrow, because you will hear more about the nuances of how we treat the axilla. You will hear some controversial data about MRI before surgery, and some thoughts from Professor Bruce Mann from Melbourne, who will, I think, give you a very good discussion on a trial that's being presented tomorrow. You'll also hear what the Japanese have been up to in terms of active monitoring with tamoxifen of DCIS, remembering that my colleagues, friends, Anne Partridge and Shelley Wang gave two superb presentations last year showing the safety, at least for 2 years, at least in American women, at least the acceptability of women in that trial for active monitoring compared to surgical removal of DCIS. So I think we're at a pivot point of learning a lot over the last year, over the last day or two, and now as we move forwards, we're going to have even further data coming along. Thank you.
Thank you. That's great. Thank you. Dr. Chang, we'd love to hear your impressions.
I find this the best time of the whole session. I love coming here every year. Probably my last year, but I love coming here. And I wanted to build on what my colleagues were saying. it's about change, and especially if we try to minimize treatments or select patients that need the treatment they need. You go from Bernie Fisher, or lumpectomy versus mastectomy, you go about looking at the axilla. All this change and then now decreasing radiation, or in the future not even needing some surgery for some DCISs, patients with DCIS, sorry. All this is change and is actually selecting and minimizing people, women who need the right form of therapy. This, you're going to bump up. You're going to bump up against, frankly, the medical profession. You're going to bump up against people who think they know the answer. And without the advocates, I think we can't do it. It cannot be done, and we cannot actually challenge what we believe is true. And I think that's time and time again is shown. But I think of the sessions, I'm going to switch. Of the things I found really, really interesting is what's in the future. A lot of it is, I'm sure everybody knows, America is now run on artificial intelligence. So why don't we talk a little bit about AI? So there have been a few talks, and there's been sprinkled throughout the whole session on the use of AI, especially more in pathology actually than radiology in this session, which is actually in itself quite interesting. But AI, there were a few talks, one with Joe Sperano in general session, and then there was a talk in the rapid fire session with lobular cancers and a few other cancers. And it's not, and it really truly is one slide versus a genomic test like the recurrence score. And to date, I think the jury's out whether or not it actually can replace it. Probably can't yet. But the data is getting there that we can better select patients based on artificial intelligence and what they call multimodal artificial intelligence by giving different types of data in. Because as we move forward, what I'm coming from to is that we're going to remove the error from humans if we can feed in the right data and actually better select who needs exactly what treatment. And I think that's where, again, the studies will come, whether you will de-escalate or you will modify therapy, and we're gonna need advocates for that. What's interesting about pathology in these sessions and AI is that pathology is probably an 18th century, 19th century invention, which is basically very variable across different pathologists. Even the measurement of estrogen receptor is variable across different people. Ki67, forget it. But anyway, truthfully, it's very variable. And I think there'll be some form of standardization based on that. One of the sessions was really rather interesting that Sunil Bhadvi also shared was looking at rare types of breast cancer. And there was a session on rare tumor types, which I spoke on, whether it's inflammatory breast cancer, metaplastic breast cancer, and phyllodes tumors. These are rare tumors with different biology. And can AI, looking at pathology, because now we still describe it, so can AI and the tools in AI actually benefit that? And so very interested in seeing where the future goes. I think there will be some personalization, de-escalation, and I think that the future of the studies that come in is going to be more precise.
Thank you.
Oh, Garrett Destin, that's all on you now. I forgot about it.
Dr. Graff.
Yeah, I am also unbelievably honored to be here. I feel like I'm in the room where it happened, so thank you for the honor of being here. We all brainstormed about what we were going to talk about. Now I'm going to talk about completely different things than I said I was going to talk about based on what they've said. First, right before Dr. Juliana's unbelievable award lecture, Carlos Arteaga talked about the need for federal cancer funding and how our federal government right now is reevaluating the budget. And so at the end of the day, I suspect most of you are registered voters, and I suspect most of you have elected representatives that represent you. And so I encourage you to use X, LinkedIn, Facebook, your email, your phone to find the person who represents you and to tell them about research that has mattered to you personally. Because in a room full of advocates, you have all been touched very personally by surgical advances, radiology advances, medical advances, radiation oncology technique advances, and almost all of those things have been federally funded at one point or another, and they need to hear that. So I'm also, in my many job titles, the Associate Director of Health Policy for Brown. So Get that voice out there. Be
Thank
heard.
you.
Be loud.
Thank you.
Hey. Number 2 and 3 are, I'm a medical oncologist. I'm a clinical trialist. I was excited by both lidERA and HER2CLIMB-05. So starting with HER2CLIMB-05. So HER2CLIMB-05 was looking at first-line HER2-positive metastatic breast cancer after good response to Cleopatra, so taxane, Herceptin plus or minus pertuzumab, and patients were randomized to continue on trastuzumab, pertuzumab maintenance, or have tecotinib added to that. If they were hormone receptor positive, they could add endocrine therapy backbone to either arm. They were randomized at the time of maximal response that they stopped the taxane. And we saw that significantly improved progression-free survival. The data is not mature yet for overall survival, but there is a clear separation of the curves. It's already, the p-value already looks good, the hazard ratio already looks good, but it's immature. So we can't say it improves overall survival yet. That's not how science or statistics work. And so, but that 8.6-month improvement in median progression-free survival on tecotinib plus pertuzumab, trastuzumab is, in my opinion, meaningful. And I think one of the most important things we can do is create a wealth of options. So now we can choose whether we want to offer first-line trastuzumab deruxtecan or first-line THP, followed by either maintenance HP with or without palbo. If you're estrogen receptor positive, based on the patina results, we'll see an update from Dr. Metzger tomorrow on patina. Or if we want to offer HP plus tecotinib plus or minus endocrine therapy if you're hormone receptor positive. And having that menu of choices with slightly different toxicity, slightly different outcomes, knowing that, of course, you can get some of those agents second if they're not right for you first is really important and helps us tailor treatment in the most personalized way for our patients. Second medical oncology clinical trial is lidERA, which looked at adding giredestrant to the early stage breast cancer treatment space. So patients with stage 1, 2, or 3 hormone receptor positive early stage breast cancer were randomized to standard endocrine therapy versus an oral SERD called giredestrant. And patients did not, and of course, we've seen oral SERDs in ESR1 mutations in the metastatic space. You did not have to have an ESR1 mutation, which is unbelievably rare in the early metastatic breast cancer setting. And patients were randomized 1-to-1. You could have any endocrine therapy, so a small proportion, 20%, if someone can fact check me maybe, had tamoxifen. Everyone else was on an aromatase inhibitor, and that was compared to the giredestrant arm. And we ended up seeing an improvement in progression-free survival. Now, the summary slide from the podium said it was a 30% reduction. That's sort of true. That's a relative risk reduction. It is an absolute benefit of about 2.7%. I think it's really important that we talk about absolute reduction versus relative risk reduction, but risk reduction is important. We haven't had a new endocrine therapy option in the early stage breast cancer setting in 20 years. So it's amazing and exciting, again, to have a wealth of options. It was also said from the podium that it was well tolerated. I would argue I'm not quite sure that that's what that data said. The safety profile, when you looked at the forest plot that they did or the violin plot that they did, showed very, very similar rates of arthralgias, very, very similar rates of hot flashes, which in my clinic every week are the two things that people are just light me on fire about on their aromatase inhibitors. So I don't necessarily know that it's better tolerated, it's differently tolerated. And again, a wealth of options is a good thing for our patients. I think one of the questions that remains unanswered is, of course, what will the financial toxicity of giredestrant be? Because it's not yet regulatory approved and it hasn't entered the marketplace, so we don't know yet what a month's prescription would cost. Many of my patients pay, $1 for an Anastrozole, and I suspect that that's not what price they're going to settle on when they take giredestrant to market. Fourth and final, as I'm going to put on my translational breast cancer oncologist hat. On the translational science side, there was a small rapid oral in the session just moments ago from Royal Marsden using the C-TREC-N data, looking at tissue-free assays to look at ctDNA. One of the real problems with using ctDNA to monitor evidence of disease recurrence in the molecular recurrence space is that some people don't have tissue, or sometimes the tissue fails to create an informed assay, which is currently how tests like Signatera or Natera work to develop that ctDNA platform. And so if you don't have available tissue, or your tissue's in another institution, the mail isn't working good for us, it's really hard to get that done. And they showed really high concordance with the tissue-free assay, and fascinatingly, earlier detection. And the better and better, the more sensitive we can get the assay, the more likely it is to make a real impact in the way that we are able to provide care for patients. I thought that was really exciting, very early, but exciting.
Great.
All right.
Would any of you like to make any further comments based on what you've each said? Would you like to? Anything else? Okay, I think it's time now for us to open it up to questions. Just a few ground rules. Please step up to the microphone for your questions so that our virtual attendees can hear. Please state your name and your organization. Questions should be asked efficiently and focused on the presentations in today's programming. Please remember that questions should not be about your personal diagnosis. If you have a second or third question, please move to the end of the line. We will monitor the screen from questions from our virtual attendees, and because we are live streaming, we'll have a hard stop at 6:45, and I'll note when we're on the last question. So it looks like we have a question. Please proceed. Thank you.
Good evening. I'm Sylvia Corral from the Breast Cancer Resource Center of Santa Barbara, California. And I have a question, Dr. Graff, because I went to that session, but I also went to the session on the immune environment. And, one of the reasons we have SERDs is because of the ESR1 mutation that develops because of the pressure of endocrine therapy on the environment of the breast cancer. So we get SERDs that actually works on the ESR1. So we're bringing something that's going to put a new pressure on mutational road of the breast cancer. And we don't know what the outcome is going to be. Does that mean when people progress, it's going to be a more aggressive disease? Do we know what we're doing to the microenvironment and the challenge by doing this? And do we need to do that for a 2% increase? Well, while we are already over-treating women to get the benefit of 10%. Right, from the normal pathology of breast cancer, early breast cancer. So that's my question, but I need to make one comment. Because the comment is to celebrate one of our advocates on the panels that was doing work on patient-reported outcomes. She did a presentation, and she was marvelous. I just want to tell you. I think her name is Asisa or something, City of Hope, LA. But if you have a chance to look at that and just look at her presentation at the end, she did a marvelous job.
Thank you. Thank you.
Great questions, yes. I think we still don't know what mechanisms of resistance are going to develop in response to the oral SERDs, but fulvestrant is, in all intents and purposes, a SERD. It's not oral, obviously. And we're very familiar with what happens after progression on fulvestrant, and we don't necessarily see activation of a more aggressive estrogen breast cancer phenotype in response to the exposure to fulvestrant. Patients have not historically stayed on fulvestrant because fulvestrant hasn't been an appropriate compound to test in the early stage breast cancer since it's a intramuscular injection. So if, as patients stay on it in the adjuvant setting for 5 years, it's unclear if that's going to otherwise change things. But we certainly in the metastatic space have patients that had long sustained responses to fulvestrant, especially as a first-line endocrine therapy backbone, even in the pre-CDK4/6 inhibitor therapy setting. And we didn't necessarily see a big shift in the environment. So I think those are kind of unanswered questions, but I would never advocate saving therapy for what if I need it in the future because I have metastatic recurrence, if I could cure more people today. Correct. So, I mean, one of the sort of complicated things is we have to move our therapies forward, even if it complicates our metastatic landscape in the future, because that's how we're going to make a difference. And right now, compared to some of my colleagues who practice, pancreatic cancer or some other malignancies, we do have good outcomes in a lot of breast cancer. So as our therapies continue to move forward, we see these smaller and smaller benefits. And does that diminish them? Not if you're the 2%, right? And so if I don't have a biomarker to tell me who the 2% is, I'm still at this point in the position that I need to at least discuss and consider that with every patient. Certainly for my patients that are miserable because of their side effects with an aromatase inhibitor or who have a contraindication to tamoxifen or whatever that might look like for any given patient. Do you want to add to the microbiome?
I want to add.
Chang wants to add to the microbiome question, the microenvironment question.
Microenvironment.
Yeah.
So what I think is what you've said is true, right? So it's not, the ESR1 mutation isn't a consequence of the treatment. So it isn't because, why does it work? Giredestrant probably works because it's a better blocker and destroyer of the estrogen receptor, very simply. And I too would not, save treatment for the metastatic setting if that hazard ratio of 70%, 0.7 or 30% reduction in progression-free survival translates into a meaningful overall survival. So it's not caused, the ESR1 mutation isn't caused by the drug. It's probably a clonal selection, if that makes sense. And I do think it's these marginal, it's an incremental step. But if you look across the board, I mean, I think in the last 20 years since we've been doing research and being in this field, death from breast cancer has dropped by 45%. It's huge. It's not for everybody. We haven't done a perfect job, but we're moving forward. And, we want to continue moving forward. That is from 45% to we can actually make sure that most people do not have a recurrence, because that's what we really, really want. But that takes research. But these are the incremental steps, and we have to bring in our therapies in earlier and earlier if it is a meaningful reduction in improvement in overall survival at the right cost and at the right side effects.
We have a question from our Zoom audience that is related to that and is also actually related to an interesting talk yesterday. The question is, because early stage hormone positive breast cancer tends to recur later, even 15 to 20 years and even later, are there any studies regarding testing estrogen production in a patient to see whether they are at risk developing metastatic breast cancer because of elevated levels? And of course,
there are, and it doesn't correlate.
Yeah. There was some talk, I don't know, we talked about this yesterday, there was some talks about latency yesterday, but thank you for answering that question in particular.
But one of the things we have to remember, I think, is that if you take tamoxifen for 5 years, it has a hangover effect, is probably the wrong phrase, but if you take it for 10 years, it also has an even longer hangover effect, and the same applies to other endocrine therapies.
And it's the problem is that when we talk about measuring hormone levels, we're measuring blood-based hormone levels, and that is very different than tissue level. I mean, blood is a tissue. Pathologists, there's pathologists in the room. But, that's very different than tissue expression or estrogen metabolism. And measuring that is not necessarily something that any of us want. No one wants to have ovarian biopsies or fat pad biopsies every month to see if their tamoxifen is working.
Yeah. Sounds good. Okay, question over here to my right. Thank you.
Okay. My name is Crystal. I am a patient advocate with Quantum Leap Healthcare Collaborative, who is the sponsor of the I-SPY trial. I had a question, which I'm sure everyone here has asked of their oncologist, and I'm sure you're getting asked this as well. I talked in the exhibition hall with a lot of different ctDNA companies, and I asked all of them, when is standard of care catching up with technology? When are we going to know what happens when you get that positive test? When do you think we will know? Because Natera says it's coming soon, but he couldn't tell me, you know, those sales folks. So I'm curious to hear from you all. What are your thoughts about the standard of care catching up? When do you anticipate that? And what do you think the outcomes will actually be?
Yes.
Everyone just turned and looked at you. I am, you know, I do think that ctDNA is going to come, and I think it's not going to come in the way that everybody thinks it will come. I actually have found some of the data really compelling in spaces that aren't what's being talked about the most. Like, there's actually a surgical trial that looked at pairing ctDNA dynamics with whether or not you need a full axillary lymph node dissection after neoadjuvant chemo. And it was very prognostic and predictive and fascinating. And so I think that there's an opportunity to sort of consider ctDNA in ways that are easier to react and respond than in medical therapeutics. The problem with the medical therapeutic space is that we haven't come up with a very elegant design, because I don't know if Serena 6 was it, that either has perfect crossover or perfect imaging and perfect data management and flawless ctDNA technology that results in our ability to see that responding to the ctDNA does something. I do think that there's value in understanding our prognosis as humans. And I think that that's part of what the patient advocacy community is asking for. The problem is getting a test back that says that you have a very poor prognosis or a very high risk prognosis that then no one can do anything about is really uncomfortable for all of us, for me, for you. And so I think we're trying to figure out how we move to that next step. Who wants to add to that?
I was going to add that I think, you know, to your point about we don't have necessarily the best designs in terms of studies to give us the, you know, go ahead that, okay, if you have this particular result, you can escalate. And then from the de-escalation standpoint, the sensitivity of the test is really critical. The last thing you want to do is tell someone their risk is not that high and, you know, not give them therapy that could be potentially life-saving. And so, but I do wonder, in terms of designing those tests and picking the right endpoints, is this going to be one of those scenarios that we sort of have to be comfortable with not having the perfect answer? And just think outside of the box a little bit. I'm sure there are some incredibly smart people that are trying to figure it out as well, but I do wonder if we're trying to, the perfect study is going to be elusive, and we're just going to have to come into an era where we look at we use a different approach in terms of assessing how to use ctDNA.
And I think that's probably what Natera is hinting at. Like, we are designing those trials. I can't say anything more than that. And we're all wearing our I'm now going to think about it as my Dr. Giuliani pants. We're all putting on our brave, I don't care what people say, it's not crazy pants when we're doing those designs. So.
I think to date they've been retrospective, right? They've been primarily, studies have already been done, and then you measure it like the PALAs, and then you basically say, hey, this group of people do better. But we really have very few studies that go, if you have a bad prognosis, what are you going to do? And I think that really is the key.
Yeah, I want to add one thing. There is a study going on right now that maybe you're not aware of, which is the screening study with this liquid biopsies being run by the Division of Cancer Prevention at the NIH, the NCI, which is looking at these tests for screening for cancer. And obviously this is what I do. I do screening for cancer with breast imaging. And the main thing that I'm concerned about is the imaging is not being standardized to assess the positive test. So there is a protocol they've recommended, but exactly what you just said, they're sort of leaving it up to the natural affinities of the radiologists who happen to be at the sites where patients are getting worked up. And the problem with that is I really don't know that we'll have an answer after this study because of that variability in the design of the workup of the patients. I mean, just to me, when you're doing screening, that is a really hard thing to prove that it works. Because you have to prove that there's changes in patient outcomes with screening. You can't just screen and hope that it changes patient outcomes. You actually have to show it changes patient outcomes. So if you don't standardize the workup, you may not really even find the cancers if they're present. So anyway, that's my concern about the study, but it's going on right now. In fact, I'm a volunteer in it, so I'm going to be a patient in it. Excellent, thank you. Yes, please.
Okay. Hi, my name is Jill, and I'm here with Mark through Teresa's Foundation. This is my first year here. So first of all, I want to just thank you for being so transparent about dogma and how hard it is for doctors to wrap their brains around changes and sort of inhibiting progress, because the people that affects are all of us in this room when doctors can't get on board with potentially new information and different ideas than they're used to. But I also, more broadly, I'm just curious how you handle in clinical practice, with the internet and with the advent of AI and all the information that patients have, how you're managing some of those patients when they come in and they've heard about repurposed drugs, natural compounds. There's a company, Every Cure, you probably know who that is. So things are popping up and patients are wanting to try things, but I know that can be very challenging for clinicians. A lot of patients aren't telling their doctors that they're doing some of these other things, which again is very challenging, especially when you need to run blood work on patients. But I hear this a lot from people, well, I'm not going to tell my doctor about that because, but that's not great. So I'm just wondering how you're managing that when your patients are coming into your practice.
Yes, please.
May I have the first go at trying to answer that? I think it's multi-step and involves more than one brief discussion. And first of all, recognizing that none of the 5 or 6 of us are perfect in our knowledge of what's going on out there in the world. The knowledge is changing, and I've learned a huge amount from patients I've had the privilege to treat over the years. And it's sometimes by listening to, you found something on the internet which may be wonderful or may be crazy or both, and actually acknowledging that. And then if if I don't understand fully what's being discussed, then sometimes taking that to the wider multidisciplinary team, because we all work in places with an imager, medical oncologist, hopefully pathologist, radiation oncologist, psychosocial medicine folks, and trying to sort of pull together our knowledge and then reflect back to the individual patient what she has shared with us respectfully. And it may be that what's being suggested actually is very sensible, or maybe not. I don't know what other people feel.
Yeah. I think it's a discussion, a long-term discussion, and I usually, my patients come in with a long list of supplements and things I take, and I spend time looking at it, and I try to look up the active ingredients, and if it's not harmful and she makes her feel better, I have no objection. So I'm sure you do the same, right, Steph?
Yeah, I mean, I guess this is why we practice in multidisciplinary teams.
Yeah.
Sometimes if patients don't tell me something, they'll tell my chemo infusion nurse or my APP or my social worker or my navigator or the intake coordinator at my front desk, like whatever.
Absolutely.
There's somebody in my cancer center that they feel really connected with and comfortable confiding in. And it normally makes its way back to the clinical care team so that we can have those conversations, which is really helpful. When patients bring me their AI says printouts, honestly, often that's a new patient visit or like an on progression visit. And I say, can we talk first and then see if I've already answered it? Because most of the time I answer what AI is going to say, believe it or not. It's either AI's right and I'm going to recommend what AI recommended, then they're like, wow, you're as smart as ChatGPT.
I went to school for this.
Like have a sticker. Ask me anything you would ask ChatGPT. Or it like narrows down the 500-page list that they want to talk about. So sometimes it helps if we just have a dialogue, and then sometimes it helps me if I just say, like, help me understand why you're asking. Because often they're not asking. They're asking because Great Aunt Betty is like really convinced that if they just had 6 kale smoothies a day, it would magically go away. And that they know that it's just because they weren't gardening kale aggressively enough this summer. And I can say, like, do you need me to write a letter for Great Aunt Betty? And then everybody feels better. And sometimes it is that they are really afraid of side effect A, or that they're really worried about what their long-term prognosis actually is, or they never want to lose their hair.
Yep.
Or like there's something that's driving this thought. And instead of talking about that, we can talk about the science that's going to actually support clear decision-making based on phase 3 randomized trials, phase 2 trials, real-world evidence trials, instead of what some guy learned on ChatGPT and is prescribing in the van down by the river.
One additional comment I was going to make, I don't know if you all heard the talk yesterday about patient autonomy. It was so striking because as a clinician, I almost have to sort of fight myself to want to tell the patient exactly how to do it. I mean, what my role is to tell them what we have evidence for and also be clear about what we don't necessarily have evidence for. But at the end of the day, the decision making, it's a shared thing, like you said. And it doesn't always come clearly across when you're having a conversation with the patient. So I think really establishing the trust, making sure the patient understands that it's not like my role is not to force you or make you do anything. My role is to present information to you, hear what your concerns are. That is spot on, because a lot of the times the questions and the comments are coming from a place of concern that if you adequately address, at the end of the day, everyone's like, okay, we're good. And sometimes patients still want to do what they want to do, and that's okay. And your role is to just help guide them through that process.
And so maybe in your role as advocates, if you're engaged in supporting or educating a community around you, I think that one of the questions are, is there a backup plan? How do I, what's the trigger for me getting that backup plan if this feels bad, if it's not working? And can we talk about that now as, could I ever choose that instead of what we've just talked about? Because I do think a lot of physicians just say, we're doing this pill or this IV therapy, and they don't necessarily say, or this one or this one or this one. But that's always there. I mean, we can always do choice B, C, or D, but time is finite and there's 40 other people waiting on me. And so I think sometimes that's kind of the question that says that if people are uncomfortable with choice A, that helps that physician give them what choice B would look like.
Thank you. Thanks. Yes, on my right, in the white t-shirt.
Hello, my name is Oksana. I'm with the Breasties, and this may be a little bit redundant, but I have another liquid biopsy question in how it pertains to metastatic disease.
Great.
So a hot topic in a lot of our stage 4 support groups has been liquid biopsies, particularly how inconsistent the use of liquid biopsies is in the space of metastatic breast cancer. I have some friends that have never received a liquid biopsy. I have friends that have received one liquid biopsy, and I have friends that are getting them every 3 months in conjunction or alternating with their routine imaging. And it sounds like right now, oncologists that are not ordering them justify it by saying the main driver of changing your disease treatment is progression, and we've determined that progression based on imaging. So why would I order something if it cannot drive a change in the treatment decision? However, and like you mentioned, it sounds like the science is not yet out yet on how we're going to incorporate liquid biopsies in 5 years. However, those of us that are metastatic are wondering in the present, should those of us with MBC who have never had a liquid biopsy or have maybe had one liquid biopsy be advocating with our providers to order them more routinely? And do we think it is helpful to pair liquid biopsies with routine metastatic breast cancer imaging, especially considering how it may be helpful to detect mutations earlier, such as ESR1? And I know we listened to some sessions yesterday saying that switching to a SERD a little bit earlier can potentially improve outcomes for those with metastatic disease.
That's a very long, nuanced question. So it depends a lot on your breast cancer subtype, okay? If you have a HER2 positive breast cancer, HER2 is the driver, and liquid biopsy, sorry, let me clarify. When I use the phrase liquid biopsy, I mean ctDNA genomics that are going to tell me if there's a targetable mutation that I can draw from blood. ctDNA is not necessarily going to change that you are going to continue to receive HER2-directed therapy. And so at this point, with HER2 positive disease, ctDNA is largely being used for clinical trial selection only. And so again, unless you have a progression and are eligible for a clinical trial or exploring traveling for a clinical trial in your region or nationally, there may not be an active role in HER2 positive disease. In triple negative breast cancer, ctDNA at baseline and at progression is very logical because, again, we're looking for targetable mutations. Most of the time, patients with triple negative breast cancer, especially triple negative breast cancer, but truly any metastatic breast cancer, should have had germline genetics. Developing a BRCA or BRCA-like mutation that we would detect on ctDNA would not be super common. There's some rare mutations like NTRK and RET that don't necessarily require, that are tissue agnostic approvals. So like we can give them to anybody with those mutations. All of those tissue agnostic approvals are very rare in breast cancer. But if we don't look for the needle in the haystack, we don't find the needle in the haystack. So we should check it. And again, the vast majority is going to be screening for clinical trial options, which is important. some patients are never going to want to do a clinical trial. Some patients are never going to want to travel for trials, all of the things. It doesn't mean that they shouldn't have access to the information so that they can consider it if one's an option at that moment. Hormone receptor positive metastatic breast cancer is infinitely more complicated right now. Thank you, Serena-6. We still don't have an approval, which makes it really hard to recommend doing that. And so I do not routinely do serial ctDNA for ESR1 detection because, again, Serena-6 was not looking at your full genomics. It was looking for ESR1. I am not checking for ESR1 to switch somebody from their endocrine therapy backbone to an oral SERD because that data is entirely predicated on an oral SERD that we don't have data to prescribe yet. And to assume that the other oral SERDs have the same mechanism of efficacy, and there's been a few presenters today that showed head-to-head comparisons of the oral SERD data, and you can see it's wildly different, which is probably in part due to the degree of binding activity that they're creating and the amount of estrogen receptor obliteration, I think you called it, which is lovely, that we're seeing when we use the different oral SERDs. So we can't necessarily say that that's a class effect. But with estrogen receptor positive metastatic breast cancer, I think patients should have profiling, whether that's tissue-based or blood-based, at diagnosis to screen for PI3 kinase, BRCA, ESR1, especially if you were treated in the adjuvant setting, and that should inform first-line treatment at progression 1 and progression 2, definitely. Again, screening for PIK3CA, ESR1, other targetable mutations. We certainly can continue to check in metastatic hormone receptor positive as we move into IV therapies. But at that point, often we are back to the space, especially if you've already been screened and already been treated with PI3 kinase targeting or AKT, P10, ESR1 targeting, that at that point, we're again back to screening for clinical trial options because we've used what's approved in the targeted space. And we don't have evidence at that point that the dynamics are going to give us more different information than radiology. I hope we get better and smarter, but we're not there yet.
I agree. So basically at the moment, it's data, it's informative. It tells you, what clinical trials you may be eligible for, especially for TNBC and HER2. For ER, hormone receptor positive, it is more complicated, and the data is getting better, but at the moment, it's the oncology, you go and mandate for all the patients with metastatic breast cancer, you mandate your oncologist test you frequently with ctDNA. I'm not sure the answer is yes to that today.
Yeah, and I think a bunch of cancer centers around the country have active registries.
Yeah.
So many of the patients, at least in my region, that are having serial ctDNA are doing it on a registry.
Yeah.
Whether they know or remember that or not, they're doing it because they're participating in research, not because their oncologist thinks it's the standard of care. And a lot of, I also get the sense that some oncologists are ordering them intermittently when patients ask because it's just the path of least resistance for that person's, they're like, okay, fine, if you want, whatever, we'll just do it. And I don't have a good explanation for that.
Thank you.
Yes, on the left.
Hi, my name is Sarah. I'm with Living Beyond Breast Cancer, and I would very much appreciate it if the panel could comment on or contextualize some of the conversations I've been hearing at this conference about ADCs. It seems like there's been conversations about selection, sequencing, resistance, diversity of payload. I know there was a presentation on the general session today that was a non-positive trial looking at, call it SASSY because I don't want to mispronounce the actual name.
Sacituzumab govitecan, it's fun, come on.
Just call it SASSY.
There's one in clinical trials that's zanidatamab, isn't that fun?
Yeah.
Yeah, so it was looking at that against chemotherapy for first line after endocrine therapy, and it was non-positive. So I just would love to hear what you are all thinking about all this ADC conversation that's happening. Thank you.
Yeah. So stay tuned for ASCO 2026. My assigned ASCO 2026 lecture is something like, what's the title that they gave me? It's ADC sequencing. What should we do?
Oh, good luck.
And I thought, who at ASCO hates me? Like, what did I do to you? Because there's no answer. What you're hearing, the tone that you're hearing is our, like, oh my God, will someone just tell us what to do? We have this general sense of dread because there's no answer, and we have this wealth of new therapies. And none of the antibody drug conjugates, ADCs, have ever been tested in sequence.
Correct.
So like all of them work, they work amazingly. We don't know if anything works after them. And that's a problem because we keep using them earlier and earlier and earlier. And I think someone over here had asked me earlier about using things earlier. And I said I would never withhold therapy because it's great that it works earlier and earlier and earlier. And now what? So I think that you're just getting our vibes about that. The current data that we have, so the approved antibody drug conjugates are TDM1 or Kadcyla. I'll use the brand names as well for you guys. TDM1, which is only for HER2 positive. We mostly use it in the non-pathologic complete response adjuvant space in HER2 positive. That's the first one. Then there was a big gap and we didn't get any. And now we have 4 new ones, and our 4 new ones are trastuzumab deruxtecan, or in HER2, datopotamab deruxtecan, and I don't actually know I don't know its name. Datroway, thank you, yes. I'm like, I actually don't know the brand name. Datroway, sacituzumab govitecan, or Trodelvy. Are those am I missing one? Was I thinking TDXD is my 4th? I was thinking I had 4. Yeah, those 3. In sequence, they all have very similar payloads. So chemotherapy that's tied. And both Dato-DXd and sacituzumab govitecan hit the same target, which is TROP2. So there's been limited studies in the real world evidence studies that look at ADC1 followed by ADC2 that suggests that response to ADC2 is low no matter what the sequence is. And there's emerging evidence looking specifically at mechanisms of resistance that says continuing a topoisomerase inhibitor payload, the chemotherapy backbone, is an ineffective strategy. And so if we're going to keep using the same chemo, it's not going to keep working. So it may, at this point, until our antibody drug conjugate technology evolves and we get new payloads and new targets, we may need to just embrace the reality that our first ADC is our ADC and we should choose wisely. And so what we saw with ASCENT-07 at this meeting, which Kamal Javari presented and beautifully, I will add, I'm going to give her a shout out for that. I think it's hard to present negative data eloquently, and she did a great job. I think what we saw from her was that moving sacituzumab govitecan in the hormone receptor positive metastatic breast cancer space to the, I'm going to say first line in air quotes, first line space, first line after exhausting all endocrine targeting therapy, which for some patients meant it was actually their 4th line therapy because they got like AI, CDK4/6 inhibitor, PIK3CA, ESR1. It was a negative study. Sacituzumab was no better than chemotherapy. We know that TROPiCS-02, which is sacituzumab just one step removed from that, improved overall survival. So sequence may matter. And we know that sacituzumab govitecan is a remarkably effective drug in triple-negative breast cancer. And now we've seen at ESMO in combination with pembrolizumab in the first-line setting. So I don't think that that's a bad thing for sacituzumab. It's just that's not quite the right space for it.
This is going to be the last question. I'm sorry, but you've been waiting for quite a while, and we've got about 3 minutes. So
I'll make it quick.
Excellent, excellent.
So you mentioned about the elephant in the room that Dr. Julian mentioned this morning, that sometimes you might not find the support, even internally, not necessarily with federal funding, with all the cuts. I'm just worried about the ripple effect, because the federal funding means that if there are cuts in that level, all your institutions also have to cut the internal budget. So what are some ways in which we as advocates can help you fight for those funds within your own institutions during challenging times?
So, first of all, thank you for raising that. Great question.
Great question.
Let's recognize that we are a global community. Dr. Giuliano presented some of the work that he has done, but many other people around the world have replicated the work that he did to make sure it got into practice. So everyone in this room, including those of us on the stage and you guys sitting there, we need to go back to our cities, institutions, and bang the drum for resources, not necessarily money, but sometimes it's money, sometimes it's the right people and the right environments to do the trials that change practice.
Agree.
Thank you.
That's a good way to end.
It is. This was such a good way to end.
I don't think I said my name, sorry. I'm Jessamine Lopez with Celebrate Life Cancer Ministry. Thank you.
Thank you.
Thank you very much.
Thank you.
And can I just add to Alastair's, and reach out to your elected representatives.
Absolutely.
Yeah.
Right, tell you.
Absolutely. Call them on the phone.
They should keep funding things.
Right.
Yeah.
I would encourage folks to come to the National Breast Cancer Coalition Summit, where we will be on the Hill pounding the pavement for you and for the people who your patients. So
And ask your physician to join ASCO PAC or ACS, CAN, or any number of physician advocacy organizations and do the same thing.
absolutely. So just a couple of wrap-ups. Hope you will come back tomorrow, both at lunch and then in the evening for another hot topic session. Please remember to fill out your evaluation form, but most importantly, I hope you will join me with a round of applause for our excellent panel. Thank you so much.